And this is the Neo version, which is a hexapod fixator. And both do exactly the same job. And it's not one is superior to the other. It's as long as whoever's using it knows what he's doing. Both you can combine the two, and both work well together as well. That's it's completely, it's a growth plate injury due to meningococcus. You can straighten, lengthen. Blount's disease is another condition. Again, nice straight legs. So this is a girl with Maffucci syndrome. You can see that as you stretch, the gap is increasing, and it forms bone. And once you take it out, that's another thing I do. Is once the fixator comes off, I put them in plaster. So everybody's slightly different. I put them in plaster till everything is sort of stabilized, the bone gets mature, and we take it off. So this is a condition of Ollier's disease. So here you can see the leg is bent here. So I've corrected it, giving him a bit more valgus, because I expect with time he's got an extra centimetre. It may start swinging again. So he's got some overcorrection to sort of sort hopefully the root cause out. Special considerations when you're doing any of these conditions is unstable fixations. And there was always this worry when you put pins and wires, they'll get loose because it doesn't have that grip in the cartilage. Now, we found that the pins, that if you use the HA-coated pin, it generally has a similar sort of level of fixation. It's always better to have one more extra pin than one less. There are some reports about bone, you're not achieving your target. You don't get the full 4 centimeters, or because it sort of forms bone quickly and it's premature consolidation. Again, that's not our experience, but children have formed bones really well, so that we've not had issues with bone formation. And it's interesting because the bone that you form by stretching the bone comes from a different way of ossification, which is known as intramembranous ossification, rather endochondral. Now, that bone never gets these endochondromas. Something to think about. So lymphedema is again whether there will be a risk for higher rates of infection. And it's probably better if there is leaky pin sites, they need to be covered with antibiotics, and that's a big risk. This is the nuclear block, which is basically intramedullary lengthening nails. These are magnetic nails, everything stays in, and you lengthen by putting this mortar next to the nail. So it's great for the femur, because femur frames are horrible. And essentially what you need is a growth plate which is closed. Once the growth plate is closed, then you can use this. And this is a good way of straightening the bone and giving you length. But all the other aspects in terms of how much length you give and what you do with the soft tissue is exactly the same, because the method is still Ehlers-Ross method. That's one of the complications, fracture. So these, again, it's a big problem. Now, what do you tell children? Don't do anything. Just sit at home. I don't know. It's a difficult one, but there's a big risk. Obviously, you don't want to do activities which puts you, at a risk of fracture. Some lesions would be more prone, particularly the outside the bone which sort of envelopes is thinned out. That's where the bigger risk of fracture. And this is one of my children who had a fracture. And how you treat it is exactly the same, and they heal very well. And fracture doesn't cure the enchondromas, you still have it there. So I'll just mention this, and I mean there are figures quoted for this, and I don't know whether how accurate these are, but I think there's the biggest multi-center European trial, but that's what those are the figures they mentioned. Again, in childhood, this malignant change is very rare, but I don't know whether how cautious. And that's exactly the same thing. So if any of my children will come and say, "Hang on, this pain I'm not happy with," I'll look at it, and these kids will get MR scans straight away. I will see them every 6 months. So again, like I said, increase in size, non-mechanical pain, night pain, and these are the descriptions which I'll say. This is what we read. I mean, this is what we tell. But obviously, education comes from you guys. I mean, you're the guys who should be writing the textbooks. And that's where we are. So this is where we are. So these are the worrying signs, and if nothing, they need to be investigated. And X-rays, MR scans, biopsies, and treatment depending upon how it is. And these are very specialist, and we've mentioned about which centres to go to, and really that's what they're looking at. And really screening, there's no really guidelines, and I feel everybody sort of does their own. We need a sort of central sort of way of agreed ways of screening this. Clinical, you need a clinical and radiological follow-up at least 6 months, and an annual MR scan, particularly for Fuji. Again, I don't have any evidence whether that's good or bad. Should it be 6 months? I don't know. Or should you do it more often when you're adult? No idea. So that's where we are, but at least an annual one will tell you exactly where we are. Or should we just wait till there are any symptoms to worry about? I don't know. So this is what we do in our practice. I think the future is preventing this to happen, and so you don't go through all the surgical insults and the pain that you go through. So I think that's where the future is. If you can stop that happening before it happens. I don't know how long it'll take, but I think we need clever people like Professor. And so I'm here so I'll be out of my job, but that's fine. Anyway, thank you very much. I think we have lots of questions, but we can take more if you want.
Maybe not so much a question, but just a point. We've been asking, our daughter's 5 years old, she's got Olliers. We've just been asking at the hospital about an MRI scan and what their thoughts are, and should this be an annual thing? Do we get one? She's never had an MRI yet at all, so it was diagnosed as the X-ray, and she's had 2 leg lengthening procedures, and there's not been a scan done or a biopsy or anything. And their official response now is that they checked with Great Ormond Street, and they don't do any MRI, so that's the position they're taking.
Yeah. That's right. So there's no right or wrong here, unfortunately, and I think it's because the way I see it is the as you say disease load to the NHS is very small. I'm not it's not a condition where you say there'll be hundreds of people coming for a scan in one hospital. It's just going to be only a few there. So ideally you want something which is very streamlined. It should be uniform, and that's what we should all work towards. Nobody knows what's the correct way of screening this is. And like I said, I can't say that what they're doing is wrong. I mean, I can't say it.
See, in our minds, we think, well, it seems to make sense that you have at least a baseline, some scan done at an early age, even though maybe the risks of living with change are very low, until we're adults. But it seems to make sense that there is the technology is there, so do monitoring that you can.
Especially if there's no side effects.
Yeah. But I think we discussed this last year. We discussed this last year that actually to put a child through an MRI scan is not always an easy thing, and I think to do a full body scan for the detail we need to monitor Olliers, for
But
example.
to put a child through a leg lengthening operation is a huge thing, isn't it? So you think for the sake of having an MRI scan versus having, do you know what I mean? They were expecting these children to have these huge operations, but then say an MRI scan's a big thing for a child to have, and in my mind, there is no comparison. You'd stick them through a scanner, surely. It just...
Is it maybe 2 or 3 hours or?
No, that's right. So I think the question is, when you screen something, there are lots of things. We used to screen for this curvature in the back scoliosis. So there used to be a school nurse going at 11. They stopped doing it because really they found out to have a screening program. What does it ultimately do? Would you pick up things? If you pick up things, would you be able to change it? So there are several questions one needs to answer before you make it into a screening program. There's a WHO guidelines about what should be the screening test for certain things. So we are really at the, so that's why it's so sort of, everybody's doing what they think is probably the best, and nobody's really a true expert. If you see, I think the biggest experts are you guys, really. I think with meetings like this, what you have is a collection of people with experience, which none of us. So I've not seen so many parents and patients with this condition in one room. So you're doing this every year, and this is where the change should come from, really. I think, and you know, this is a learning process for me. I mean, I've learned a lot from you guys, really. So I think so, and that's what it is. And yes, if this makes us go to some sort of you know, standard of care pathway for all years in the food chain, and I think it makes it in terms of diagnostic criteria is how you manage different aspects of this. That's where the future is, at least in the short term.
I think with the adult screening that you're doing as well, it would build up a really important picture as to what children should be having once they're diagnosed, screening-wise, as children, to prevent complications later on in life.
Because that's what I was going to ask. I'm asking as well. So in terms of, you know, my children, so it makes sort of sense that they come and see you, or we sort of.
Well, I think, you know, as I mentioned, this kind of a network where we share experiences, because I think everybody will have very, you know, knowledge, but they're sharing it. And I think setting up a network, a medical network where we could go for standardizing things, it may not be the right one, but maybe 2 years down the line, then you find you have to modify it. But at least one could build on something and go towards building up a consensus as to how to manage. Yeah, I think it's very difficult with very small numbers, small numbers of patients, but also then small numbers of doctors with the experience.
Can I just ask one really quick question? I've gone up to you.
Okay, sorry for my English, I'm not sure about it. We come from the French Association 15 years ago, and we found a tumor in the in the skull.
Yes.
And quietly 100% of the patient are affected by this tumor. And you have to make some X-ray every year, because she's growing very slowly, but one time is too big. And nobody knows that. You don't speak about it. I think it's important to know. You have to check the skull as well.
Every year, and they talk about it in the French Association every single year, how you kind of have to have a skull MRI, because as we said, everyone that's checked so far has a tumor in the nasal cavity. I had a biopsy for it. It's a normal tumor, but still, it can lead to really bad complications. It can grow, it can affect eyesight. So it needs to be checked.
And another point, I don't know if you have in UK, the EOS system for the X-ray. This is like a shower, but it takes some pictures of all the bodies, and the effect of the X-ray is very low. Like
It is there with not all the sensors, but there are EOS systems.
So are they better than an MRI scan?
An MR scan gives you the whole, you know, that's really looking at bony bits. But
Right.
MR scan looks at your.
So you get more information from an MR. So that's why they've done it.
Sorry, just really talking there about the tumour. My son had a problem with his vision and chronic head pain last November, and this went on for about 4 weeks. He couldn't see properly, couldn't mobilise, disorientated, and I was obviously concerned with what people said about the skull and that sort of thing. He had an MRI, but there wasn't it wasn't showing a lesion or tumour there, so that was something that I thought was potentially symptomatic of a problem going on, but there wasn't something, just in case there are other parents.
Ellie's had an MRI of her brain and skull, and there was nothing there either, so it's.
But my son's 11, so no.
Sorry.
Maybe.
Yeah, just, when you said about the annual MRs, do you do that instead of x-rays? Ellie has lesions everywhere, and I think she's going to start glowing in the dark soon, the amount of times you have to go and the amount of x-rays they do, and I didn't know if you kind of use that as an alternative to x-rays for like an annual review, or whether you do them alongside.
So, I being an orthopedic surgeon, love x-rays. I love x-rays because I can look at them, I can compare them, whereas I think you get more information from an MR scan. But there's no right or wrong here, and I think because most of it is because we don't know, and really, you know, MR scan comes with a price. You know, sedation, admission is a big deal. X-ray is just a slap. But is it? I don't know. So it's a difficult one. Sorry, that's why I put the slide. You know, orthopedic surgeons don't talk about intelligent stuff. Is that it? I'm sorry. I think it's
No,
just
it's all
carried
good.
on.
It's all good. Can we say thank you to?
Thank you.
There are a few things that came up in there that I just want to clarify. We do have our medical advisory board, which we are building on, and we've got different expertise and skills coming into that. We've also got a working party where we've got medical professionals coming into that. What I would love to do is have an event like this where the people sitting here are the medical professionals, so that they can thrash it out. I will just do the teas and the coffees because I won't understand anything. But I think it's important that we do have an event like this that is for those professionals, and that is what I'm trying to build up at the moment. It just needs a bit of time. So these things will be happening, and they're talks that I've had with Professor Flanagan and Mr Ashford. We're in constant contact about how we're going to move things forward, and we know what the next steps are and what we want to do. And one of the main things is protocol, a system in place, so that someone in the south isn't doing something different in the north, and you know, just having a guideline, a basis that our consultants are working towards for treatment and care, and particularly diagnosis as well, because I've heard a lot of stories with regards to diagnosis and how that's being done. So to let you know, it is happening, but it's all behind the scenes and things take a lot of time. So, but these things are in the process. So, yeah, it's you guys that help with that. Lunch is now ready, so if you would like to go through, help yourself to that. Children's is on the left. If you've got special